Hello, hello. All right, so I'm going to talk about the mental status examination in psychiatry. This is a kind of unique part of our examination compared to other specialties. And I'm just going to kind of go through the different components of the mental status examination and give my thoughts on them. And I'll say that the mental status examination can vary from clinician to clinician because unlike the physical body, where there is a set of discrete organs and regions of the body that we can point to and all agree what that means, the mental status examination, given the brain's many cognitive functions and many ways that you could try to divide things up into things that you can test, it's just not as objective to do that sort of thing when it comes to the brain, right? So, for the most part, however, there is a fairly conserved approach to the mental status exam from place to place. But I do just want to say that you're going to see some variation. So, what I'll go over may be a little bit different from what you're used to, but that's okay. So, what is the mental status examination and what is it for? Maybe let's start there. So, the mental status examination, in my view, is basically a snapshot of a person's appearance, behavior, presence, and cognition or mental state at the time of your interview. Now, sometimes we need to average this out over the course of, say, 24 hours because you might catch a patient at a particularly good time and everything looks normal, even though they're not normal. You just caught them at a good time because psychiatric disorders can be quite dynamic. And so in actual clinical practice, we often may average some of these things out, especially in the inpatient setting over the course of, say, a day, to get a more realistic picture. But I'd say more in principle, the mental status examination is a snapshot of how they were during your interview so that you could read through that and basically imagine what it was like to sit there with that patient. If you read a mental status examination, you should have a rough idea of what it's like to be with that patient, what they look like, how they were acting, how they were behaving, how they respond, how they're able to understand their own condition and all that stuff. Okay. So usually the first thing in the mental status examination is the appearance. And, these days, now that patients have access to their medical records, I think a lot of us are maybe less descriptive than used to be the case. In the past, you might say something like, this is a Caucasian male who appears older than their age. They've got tattoos on their face or all that kind of very descriptive stuff. A lot of times that's pretty watered down. For the most part, I'm mostly commenting on, does their appearance look appropriate or is there anything sort of odd or unusual about it? I might comment about bright colored hair or facial tattoos or something like that that stands out. Their overall, how put together are they? Are they well groomed or are they disheveled and unkempt? Are they malodorous or not? So basically, kind of revealing their level of hygiene, which can indicate their level of functioning and self care. Okay. Next, after appearance, and again, the order is not so much important. These could be in any order. Next, I'm usually thinking about psychomotor activity. So, are they psychomotor slowed, which could be the case in catatonia? Are they psychomotor agitated or excited? More accelerated, which might be the case in acute psychosis or mania? Are they restless? Are they just fidgeting and hyperactive? That might be the case in more of a ADHD presentation. Also, here is behavior. Behavior is more just how they relate to you. How does the patient relate to you behaviorally? And also, just if you observe them walking into the interview room or right prior to the interview, or your observations of them in the milieu, are they well related? Are they cooperative or hostile? Are they oddly related? Where it's hard to put your finger on it, but they just don't connect well with people. There's just sort of an odd social dynamic happening. Do they have good eye contact or poor eye contact? Are they fleeting? Are they suspicious? Are they guarded? Or they seem to be withholding back some information? Are they disinhibited, perhaps, which might be the case in mania. So these could all be things you say under behavior. And some people will differentially lump things together or split these apart. So I'll usually do appearance, behavior, eye contact, psychomotor activity. Those are all oftentimes separate lines in my mental status examination. Then you've got speech, and usually we're commenting on the volume of their speech, how quickly they're talking, and the tonality of their speech. So if somebody is manic, we might say that their speech is pressured, and that's where they're talking in such a way that there's basically no interruptions in their speech. So usually in normal conversation, people will say some thoughts. They may pause just because they're thinking of what next to say, or they're maybe waiting for you to comment or reply on what they're saying. But someone who's manic and they've got pressured speech, there's just no delay between thoughts, right? It's just one after the other after the other. Sometimes it might be pressured, but you can interject. And other times, if they're really manic, it's just very difficult to interject. Sometimes speech might lack tonality. It's very monotone. Speech might be slow, or there might be latency, which refers to just a delay in speech when they talk, which could be the case in catatonia. Their speech could be unusually loud, inappropriately loud if they're agitated. Okay, then there's language after speech. That's usually a separate category. And that's really commenting on their use of language, their diction, their fluency. Are they having any linguistic errors, such as a paraphasic error? Maybe they're substituting words that are sort of inappropriate, even though their tone and rate of speech and volume might be totally normal. Their use of language might be abnormal. This is usually not the case in purely primary psychiatric disorders, but might be the case in more neuropsychiatric disorders or neurological disorders like in dementia, where you might have these kinds of paraphasic errors. Okay, so after language, you have mood. And mood should really be a quote if possible. And this is literally asking the patient, describe your mood to me right now. So they could say, my mood is good. They could say, my mood is sad. They could say, my mood is anxious, or whatever they want to say, right? Ideally, you just put that into quotes, and that's the mood section, because it's really just a subjective description of their emotional state. So after mood is affect, and affect is how other people perceive the patient's internal emotional state to be. Now, of course, people could disagree on this. You might call mood subjective and affect objective. Affect can still be up for interpretation, but I think it's just a matter of what would a majority of reasonable people say about this person. If someone is clearly not smiling at all during a conversation, maybe frowning, showing little emotional reactivity, that patient does not appear to be in a good mood. So I like to think of affect along two dimensions. One being the range of affect they show over the course of an initial evaluation that could be an hour. Oftentimes there might be periods where you're talking about sad things, anxious things. Maybe you make a little quip or a little joke, and ideally the person is going to be responding to that dynamic appropriately. And so if they're able to kind of show their sad side and their happy side and maybe their surprise side, then they've got a full range of affect. Their affect is full range. And I would say it's full range and reactive, right? Because they're reacting appropriately to stimuli. The other dimension is basically the amplitude of their emotions. So someone could have a full range reactive affect, but the sort of amplitude of their emotions is either exaggerated or blunted. So, for example, oftentimes people with schizophrenia at least have blunted affect, where they might smile, might be able to laugh a little bit, but it's just much lower in amplitude than you might expect given the stimulus. A flat affect would be basically the amplitude is 0. So, and they're just sort of stuck in the middle. They don't really show any emotion. Moving on, we have thought content. So thought content, generally, we're back to asking questions of the patient's subjective experience, just like we did with mood. So there are several things that we could ask. One is if they're having suicidal thoughts, if they're having homicidal thoughts, if they're having any delusions. Now, if someone's truly having a delusion, you can't just ask them, hey, are you having a delusion, right? Because they're not going to be aware that it's a delusion. But if I'm suspecting psychosis on the differential, then I will ask things that might elicit common delusions. I might ask, do you believe you have any special powers or abilities? Do you believe that people can read your thoughts? Do you believe that you can read other people's thoughts? Do you feel paranoid that something bad is about to happen or people are out to get you? Now, also just in the course of the conversation, they may tell you some of these things, right? They might just volunteer on their own that they believe that they have a microchip in their brain that was installed by the FBI and now satellites are controlling them, right? There may not be a good question to elicit that, but they might just tell you that at some point. And so that would also go under thought content, and you could write down that they're having paranoid delusions. Next would be thought process. I also kind of think about thought process along 2 dimensions. One being how organized their thought process is. Are they able to stay on topic? Are they able to string together a coherent thought? Or in the worst case, it's grossly disorganized and they're just saying random words. Thinking about modern AI models, like these large language models, they basically do next token prediction, as it's called. So you feed them a few words and it'll predict what the next word ought to be. But there could be multiple plausible words that follow a given context. So a well-trained large language model is going to predict a word that makes sense in the context of the preceding words. It's going to follow an organized, structured pattern. If it is not well-trained or corrupted in some way, it might predict a word that's totally irrelevant. So if you gave the large language model, why did the chicken cross and the large language model predicted time-space continuum, that would be weird, right? That's not really associated. So, or even worse yet, if it shows the wrong part of speech, why did the chicken cross the love? It predicted that word, right? That would even make less sense because that's not even the right part of speech that should be expected to follow. So, similar way, people's thought process can become more or less organized, meaning the pattern of their speech, the pattern of their thoughts, the pattern of their words can be more or less coherent, more or less associated with each other and on topic. And then related, it's hard to totally disentangle these, but related would be how logical the thought process is. So they might be able to string together a coherent sentence or coherent phrase, but the larger pattern of their reasoning ability doesn't make sense. But they're definitely connected, because if your associations between thoughts are loose, then you're not going to really be able to be logical. So some words to mention here, some common terms here are, linear, organized, coherent, or the thought process could be perseverative, rambling, impoverished, if they just don't say much. Circumstantial, which is where you might ask them a question and they kind of go off on some unrelated topic before finally getting back to your question. Or tangential, where you ask them, so why did you decide to go to your friend's house? And they start talking about a baseball game that has nothing to do with what she just said. They could have thought blocking, where maybe they start talking and then all of a sudden they just stop talking mid-thought and then maybe get back to talking again a moment later. They could have flight of ideas, which is associated with mania, where their thought process is is really revved up and they just keep coming up with new and new ideas. Moving on, there is the perceptions category. And this is where you're asking about their perceptions. Do they have any abnormal perceptions? Are they having any hallucinations? So there's not great ways to go about this because oftentimes when people are having hallucinations, they don't have insight into it. But, oftentimes we're just asking, do you hear voices in your head when you're alone? Do you see things that I can't see? Do you feel things that I can't feel? Now, again, if they're really in the depths of a psychotic episode with lack of insight, which we'll talk about later, they may deny all that, but he may still appear to be interacting with things that aren't there, talking to people who aren't there. And so we call that being internally stimulated. Next is sensorium. And sensorium is basically their alertness level. So are they awake and alert, or are they drowsy? Are they uptunded? So those kinds of words. Next is cognition, and this is a whole kind of new section here. First, you have memory. Is their memory grossly intact? Are they able to remember details of your conversation? Usually, I like to give them 3 things to remember. Like, I'll tell them, hey, I want you to remember these 3 words: penny, apple, chair. And I'll have them repeat them back to me just so I know that they registered it. And then there's not an immediate recall issue. And then I'll tell them that I'm going to ask them about that later, so try to hold on to it. And then I'll go through some other questions. I'll check their orientation. So I'll ask them to give me the full date, including the month and year. Then I'll ask a question to assess their attention. And so usually I'll ask them to spell the word world forward, W-O-R-L-D, and backward, D-L-R-O-W. Or you could have them do the months of the year backward, as in December, November, October, etc. And so you've got to have intact attention to be able to do those tasks. Then I'll test their fund of knowledge. Usually I will simply ask them to tell me the current U.S. president and the first U.S. president. Kind of gives you an idea of how well they're paying attention to current events and their kind of general education level. You could also test their language ability. So you could point to objects and ask them to say what they are. You might hold up a pen and ask them to name what it is, or point to the phone and ask them to say what that is. And then for judgment, the classic example is give them a hypothetical situation, like they find a stamped letter next to a mailbox and you ask them what they would do with it. And so the quote unquote right answer would be to put it in the mailbox. I usually ask something along the lines of, let's say you're shopping in Walmart and you start to smell smoke. What would you do? And it gives you an idea of how they approach that situation. If they have good judgment, they're going to do something along the lines of getting out of there, alerting staff, maybe trying to figure out where it's coming from and then alert staff, right? There's lots of reasonable answers there and lots of unreasonable answers. I've heard people say that I would do nothing. I've heard people say that they had no idea what to do in that situation. So some examples of bad judgment. And then I'll ask them, hey, do you still remember those 3 words that I asked you to remember from earlier? Now this has insight, which is another component. Insight is basically how much do they understand about their own current situation, their own mental illness, their own mental states, right? So someone might have hallucinations and be able to tell you, yeah, I'm hearing voices and that's not normal. I can tell that there's something wrong here. I've got hallucinations. And so they've got preserved insight, even though they might have some psychotic symptoms. Whereas someone else who's hearing voices may have no idea that that's abnormal, or they might think the voices are from a microchip that was implanted or something. In that case, they have no insight. So the level of insight might be apparent to you just from the conversation that you've had during your interview with them. Or oftentimes I will have to ask them, so do you have any idea why you're in a psychiatric hospital? And if they're able to tell me, yeah, I was behaving erratically or whatever, then they've got pretty good insight. But a lot of times the people with frank psychosis, they'll say, no, I have no idea. I'm perfectly fine. And I don't have a mental health problem. Right. So that demonstrates very poor insight. So those are the main components of the mental status examination. By kind of going through that, by looking at a well done mental status examination, you should be able to come up with a pretty decent differential diagnosis just on the basis of that, at least for severe things that we see in the inpatient setting. If you're in the outpatient setting and someone says that I've just been really anxious, but maybe they don't present very anxious, or if you're seeing someone for, I don't know, specific phobia, right? Their mental status exam is going to be probably completely normal. But if you're seeing someone and it's something severe, something that other people can notice, then your mental status exam should lead to a decent differential diagnosis. And you should be able to imagine what it's like sitting in a room with them and talking to them. All right. Well, hopefully that was helpful.